Hi everyone, this is Mr Neel Raithatha, also known as the Wax Whisperer. Thank you for tuning into my latest video. The patient in this procedure attended with bilateral, fully occluding earwax. The earwax is a dark brown shade, almost turning black, which means it's been in there for a while. The longer earwax is in the ear, it oxidizes just like an apple or an avocado. As you cut into it and slice into it, it does turn from earwax turns from a light brown colour when it's freshly secreted into a darker shade of brown, almost a black appearance. What's made this procedure more difficult is the patients used hydrogen peroxide drops, which I'm not a big fan of, and also used Q-tips, so what we call in the UK cotton buds. The reason why I'm not a big fan of hydrogen peroxide drops is that it has a tendency of turning the wax into a mushy consistency, and it can block the suction tube. You might have seen there, and again now, the suction tube just got blocked, and I was just giving it a little wriggle, trying to unblock it. And wax that's been soaked in hydrogen peroxide has a tendency of sticking to the ear canal wall as well. It's just, if you watch my videos, you know I like food analogies. I just compare it to mashed potato. It's a similar consistency, and just imagine trying to suction mashed potato with a 2mm suction tube. It's quite difficult, to say the least. The Q-tips have obviously impacted the wax more medially into the ear canal wall. You'll see when I remove this plug of wax, it's impacted in the anterior recess. So near the eardrum, the ear canal narrows and then it widens. It's about 0.5 centimetre away from the eardrum. It's called the isthmus, which creates two recesses. It creates a trench at the base of the ear canal, known as the inferior recess, where wax can get trapped, and also one at the front part of the ear canal. So in the case of the left ear, the ear that we're in at the moment, the anterior recess will be on the left-hand side. It's like a little trench, a vertical trench. What's great about the endoscope is the field of view. We can see at the moment the whole ear canal wall, and if you've been watching, we're just slowly just lifting this off the canal wall, separating it from the back part of the ear canal, so the posterior portion of the ear canal, the roof of the ear canal, what we call the superior ear canal, the front part of the ear canal, the anterior ear canal, and the base of the ear canal, the inferior portion of the ear canal. And when we can see the whole plug of wax in its entirety in the ear canal, it just facilitates a quicker, more efficient procedure, because we can just gently loosen it off the ear canal wall and mobilize the plug of wax. That's what's key. We want to mobilize it. Earwax has a tendency, as the earwax progressively builds up, it compresses, it squashes outwards against the ear canal wall, causing it to stick, and then you get skin adhesions. Skin adhesions are like double-sided sticky tape. You've got one side of the skin that adheres to the ear canal wall and the other onto the surface of the plug of wax, which can make it more difficult to remove. It's almost like a tug of war sometimes. So remove the majority of the occluding earwax. Now this is really medial, up against the eardrum, within the isthmus, and I'm just trying to lift it off the base of the ear canal and the anterior part of the ear canal, but it is well and truly lodged. And if I carry on, it's almost going to be like me spreading butter on a piece of toast. It's got that consistency this wax has. So I'm going to put some olive oil earwax drops in, not too much. It's something that I started doing a few years ago, just out of, I just thought I'll try it, because typically we would get patients to go home, use drops if the wax is too impacted or mushy, and return. But I thought, well, let's do it during a procedure, why not? And it's worked really well. So I've taken that up to the next stage. So whereas before, well, I still do, I used to soak the ear canal with drops for a few minutes and get the patient to tilt the opposite way to drain it. But what I try to do now is try to perform the procedure whilst the drops is in situ, which makes it sometimes a bit more difficult, because you can get some blurriness, some fuzziness as you're suctioning the wax. You're suctioning some oil as well, and it can blur the tip of the endoscope. But it's a bit of a skill, and sometimes it works really well, like in this case. So just at the roof of the ear canal, it's just got blocked there. I'm just trying to loosen this off the tympanic membrane, because it is impacted against the tympanic membrane. Slowly but surely, I've just loosened it there, just mobilized it. You can see these little motions, these little wriggle movements. These little wriggle movements just help detach the wax plug from the eardrum and canal wall, and there we are. So I called it a slab of earwax. You'll see at the end, still image. They look like large slabs on both sides. So you've got some residual soft wax on the ear canal wall. We leave that. It's not going to cause a problem. Just mopping up right near the entrance, because this is the cartilaginous portion. That's fine. But if we approach the inner 2/3 of the ear canal, the bony part, there's a bit of skin there. Just be careful because it can clone out. We leave the rest of it there. It's on the bony part. It's not going to cause a problem. It's just residual wet wax because of the drops. It's just staining. We all have a bit of earwax. A bit of earwax is good for us. So just onto the right ear now. I've immediately put some olive oil drops in there because of the consistency. It mirrors the consistency of the left ear. And again, just using dissolver suction probe. So this is called microsuction. The term microsuction is actually somewhat misinterpreted. So typically, historically, should I say, not typically, but historically, earwax was performed, at least in secondary care, by ENT specialists and ENT nurses in the hospital using an operating ENT microscope. And that's where the coin microsuction was first developed, and it was believed that it's because they're using a microscope. That's where the term microsuction came from. However, I've read literature suggesting something else. It's not. The word micro doesn't originate from the use of a microscope to visualize the ear. It's actually just because the suction probe is really, really small. It's narrow. So the instrumentation we use for earwax removal are called ENT micro instruments. So the micro instruments can include the suction probe, ear hook, a Jobson horn, a curette, forceps. So I don't know who's right, who's wrong, but it's just another definition of microsuction. It's because we're performing suction using a micro instrument. So again, just look at that view. You can see the whole perimeter of the ear canal. So the field of view is so amazing. And the great thing about the iClearScope, the endoscope that we use, what we've developed, is you don't get a loss of focus. I see some videos out there of some other devices, and the suction probe is completely distorted. The tip of it is not in focus, and it's almost like it doesn't look like a suction probe. It's distorted so much that it's got two colours. The nearest part of the suction probe is black in appearance, whereas the distal end is silver, as it should be. And it's almost like a bend at the tip. It's really weird. But with an endoscope, you don't lose that. The focus is so great, and the focal depth is great over a great working distance. So, as I said, the second installation of olive oil drops has done the trick. Again, it's a bit wet around the edge. It's all fine. The main thing you can see on the anterior medial canal wall is a bit of staining. I'm not going to touch that because that's just going to be very uncomfortable for the patient. I hope you enjoyed that video, guys. Again, another slab that I got removed there, and you'll see these still images on screen now. Quite large. I weighed the wax as well, so it was quite a big haul. I hope you're all keeping well and safe, and I'll speak to you soon. Bye.